Aziz Bhai, you can proceed.
Assalamu alaikum, everybody. One thing that I'd like to know is this, are the participants all from Bangladesh, or do you have any foreign students or participants today? Because otherwise I can mix with Bengali so that it will be better to understand from a lot of our trainee physicians. Anyway, I'll try. Definitely I can.
I think most of our attendees are from Bangladesh.
Okay, then I'll mix that so that it will be easy to understand. Okay. Assalamu alaikum everybody. আজকে একটা আমি যে টপিকসটা নিয়ে আলোচনা করব সেটা আমাদের মেইন ফোকাস, যেটা আজকের ডিসকাশন আমাদের ট্রেনি ফিজিশিয়ান, ওকে, যারা এমডি করছেন, কার্ডিওলজিতে ট্রেনিং নিচ্ছেন, তাদেরকে ফোকাস করেই করা, এবং ইয়ার ফিজিশিয়ানস যারা এমার্জেন্সি রুমে কাজ করেন তাদেরকে ফোকাস করে করা। কারণ হচ্ছে কি যে certain things that we know obviously when there's ST elevation there, then definitely it goes to different category. And যখন there's subtle change in the ECG, we're not sure but the patient has symptoms or not symptoms, what to do with this situation, because sometimes it's very important to diagnose that, recognize that, কারণ ওগুলো মিস করলে কিন্তু এই ধরনের পেশেন্টদের they might have significant cardiac event and potential death. So that's the focus of my talk. So let's proceed. First যেটা কেসটা আমরা দেখবো যে 45 years old female with a history of hypertension presented to the emergency room with left-sided chest pain, 7/10 in intensity with radiation to the left arm. And the patient, she had some nausea, diaphoresis that lasted about 15 to 20 minutes. That's the reason she came here, but it happened about 30 minutes ago. So when patient reported to ER, she was pain-free basically, okay, and but she definitely had pain about 30 minutes ago that lasted about 15 to 20 minutes. And patient reports this pain she has been experiencing that with emotional stress, sometimes with activity, and her medications lisinopril, amlodipine, and the ECG I'd like to show you below. So I would like to get participation from our audience, trainee physicians. Anybody would like to comment on that? Please participate, because nothing to worry about. We'll discuss definitely in depth. Please participate. Okay, anybody, just, yes, Dr. Naim Hassan.
Assalamu alaikum, sir.
Alaikum assalam.
Sir, in this 12-lead surface ECG with proper standardization and proper lead placement, and heart rate is 75 beats per minute. The rhythm is normal sinus rhythm. Axis is normal, and there T inversion in V1, V2, V3, V4 and V5 also. And there is no loss of R wave height in that leads.
Okay, it's a nice presentation and a discussion. Let's go to before you go to the conclusion, I'd like the audience to participate with the following questions. You saw the ECG, you saw the presentation. The patient had chest pain about 30 minutes before she came to the hospital. And during the examination, she was pain-free, but this is the presenting ECG. Let's go to the next things. Can audience participate in the question? Amra question gulo answer kori. I'd like to see the distribution of that. Should we start her on aspirin, heparin drip, beta blocker, high dose statin, and treat conservatively since she is pain-free? Should we get an echocardiogram to assess LV function? Or should we send her to emergent heart catheterization? Or should we schedule her for pharmacologic myocardial stress testing for assessment of ischemia since she's pain-free, and if there's no significant rise in troponin, there's, whether we should consider that on the next morning. Or whether suspecting something else, so there's any pulmonary embolism, sometimes they can present some T-wave abnormality, whether we schedule for CTA for suspected pulmonary embolism. Please answer those questions. I'd like to see the distribution.
So poll, please. Kamrul, poll, please.
This is a practical questions to you. You're seeing the patient in the emergency room and what you want to do with this presentation and ECG.
Kamrul, poll started. Hello, Kamrul.
All right, can you post the results?
Hello.
If not available, then you can go forward. Okay, we'll see. Okay, yeah, please vote. Okay. We have only 4. Just vote on the 4. I think it should be okay. The choice is in between. Okay. Please vote.
Together.
All right, so we have a different distribution, interesting enough, okay? So let's discuss that, because I'd like to see the distribution that tells us among our audience how much, they have good understanding of the problem, because that's the thing we need to focus of defining, explaining, so that they can learn more on these situations. So the ECG that we saw, let's go back on that. Can you remove that? Okay. We see that T-wave inversion there, okay? The question right now, any patient comes with this type of T-wave abnormality, and they have some concern about chest pain syndrome. You cannot ignore those. You cannot ignore those. Okay, the question right now, there's a terminology we call like biphasic T-wave or inverted T-waves. With the current constellation of symptoms, then you need to think about Whelan's syndrome. Okay, there's a syndrome called Whelan's syndrome, because these are the situation that sometimes patient really, if you don't address the situation, because they have some occlusion there, and they can have different arteries, but most commonly we see in the LAD, and they can, we call stutering angina, because they're reperfusing themselves, opening themselves, reperfusing themselves and opening themselves. And it can come to the point that it can occlude totally. Then we'll see hyperacute T waves, and we can see ST elevation. And this type of patients can go to acute ST elevation MI, and definitely the subsequent cardiac event and potential death if we miss the situation. So here, as we point out here, it's called Whelan's syndrome, and I'm going to go into depth of that. So as we see on that, in Whelan's syndrome, it's kind of emergent situation. You cannot wait, you cannot treat the patient conservatively since it's pain-free. So 30% of audience that answered A is not accurate. In that sense, this is kind of emergent situation, dynamic TOF changes. They need to go to the cath lab. You don't waste time. You can do an echo, but it's not emergently you need to do that right now. You need to send her to the cath lab. But definitely when this type of patients have dynamic TOF changes, you do not want to put them in pharmacologic stress testing. What's going to happen? They can precipitate acute MI because they have very little reserve, and they can cause total obstruction with the stress test, and you can precipitate event in the lab. That will be more problematic. So the patient needs to go to the cath lab, and the patient went to the cath lab, and definitely they had a proximal LED lesion. It was actually tight lesion, and patient underwent stenting. Okay. So this syndrome was described initially, Dr. Whelan's group, in 1982 in American Heart Journal. They presented a few cases because they saw this type of phenomena like biphasic TOF changes. Okay, they could type A and type B. I'm going to describe that later on. Because if you're biphasic, like some positive and the negative TOF, then it's called biphasic type A. Type B that we saw in our case, deep TOF inversion, that is type B. And they very nicely presented that most of them initially they presented the cases, 100% of them had LED lesion. But subsequent, more data coming out from different labs and different literature, it shows that not 100%, maybe 50% has acute critical lesion. And not only that this lesion can happen not only in the LAD, it can happen in the circ, also it can happen in the RCA territory. So, and it's very important that this lesion is highly unstable and there's high chance of reocclusion. Though sometimes they can have stitutory angina, they come and go. When you have that history, they come and go, you need to go in and try to go immediately to the cath lab. So how we manage those patients? Definitely very quick recognition and quick intervention, as I mentioned. And most commonly, they require PCI with stenting, okay? And as I mentioned to you, that a lot of patients answered that probably you could do a stress test. The stress testing is contraindicated in the Whelan syndrome because it can exacerbate, once again, I'm repeating that, the limited reserve blood supply they have to the myocardium and precipitate myocardial infarction. So this type of ECG, and they have clinical symptoms that chest pain comes and go, you should not put them to stress test those type of patients. So what are the criteria for Whelan syndrome? One, there's type B, type A that we talked about, biphasic. Initial part is positive and the negative biphasic TOF. Type B is TOF inversion. Totally, it's a deep and symmetrical TOF inversion. And 75% of the time is in the LED territory and mainly in V2, V3 most commonly, but it can happen also V1, V4, V5, and V6. But they have other criteria also because the ST, they don't have ST elevation much. They have isoelectric or minimally elevated. Sometimes it should be less than 1 millimeter. And there's no Q waves because they haven't infarcted yet, but they're going to happen. It's going to happen. But they have to have angina, like on and off angina. It could be stress-related, emotional stress, or exertional, just a history of angina. And but when they present to the ER, or to you, the most, and we see those EKG, they are normally in pain-free state. That's a very important point. Because if they have pain going on in the ECG, that will fall into category of acute coronary syndrome, okay, unstable angina, or non-ST elevation MI if they rule in for by troponin. But the pattern of the Whelan syndrome, that the presenting state is pain-free state. That's one of the differentiation of the criteria. But they can have some either normal enzymes or slightly elevated cardiac enzymes. But definitely you need to look at those criteria to call it Whelan syndrome. But management, take quickly to the cath lab, and most likely they will need intervention. Let's do a second case, okay?
So, Dr. Hall,
Yes.
So is there any question for the case
Yeah,
one? I want to
yeah.
ask. But before that, I have a
Should-
question. I said,
Yeah. Mhm.
is there any explanation where the patient is pain-free? Do you have any explanation?
Yes. What's happening? There's a lesion there, and there's a plaque there. Plaque, probably rupture, but there's some clot formed initially. Clot might have resolved because naturally we have our fibrinolytic system in our body. Okay, there's natural fibrinolytic system. Sometimes they resolve. Okay, and the resolve, they get pain-free because their flow restored. But they can have again a clot formation. Okay, that's the time they present is pain-free. That means their blood flow is still going. That's not totally occluded. That's one of the understanding of that, because natural fibrinolytic system is still working. Okay, but it will fail ultimately. All right, because the reason is what in one situation I can tell you that we have some patients that coming with this chest pain, some ECG, and you give some nitro, they open up. Okay, nitroglycerin, they become pain-free, and they see the EKG might normalize. Okay, so because of restoration of blood flow in the nitroglycerin, because they're not totally occluded. Okay, that's the understanding of that. Okay, any other questions you have from the audience?
Abdullah Jamil, any question from the?
Yeah.
No, please go ahead.
And you can comment also, please, panelists, because I'm not interventional cardiologist. I just see those patients, and you have more experience probably, but you can comment on that. Okay. Let's look at the second case. This is a 56 years old male with a history of smoking, presented to emergency room with intermittent substernal chest pain for last 2 weeks. The difference between the previous case, this patient has continued pain while in the ED. Okay. Blood pressure is there, stable, vital signs stable, unremarkable physical exam, and the ECG shows all right. Anybody can comment on that ECG from the audience?
Anyone can raise hand from the audience. Naim Hassan, you can.
He's one of our brilliant doctor here. Yes, please. I think it's not much. Yeah, you can comment on that quickly.
Sir, here normal sinus rhythm, heart rate is 75 beats per minute, and there is T inversion in V1 and V2. Otherwise, it looks normal. V1, V2, and V3 also, sir.
Yes, so definitely the starting point, there is some biphasic T-wave changes. Okay, that's the focus of this in ECG. And if you look at that, let's look at the questions, then we'll go, do the question and answer. So should you start aspirin, loading dose, ticagrelor, heparin drip, beta blocker, high dose statin, and plan for heart cath in AM? Or just get an echocardiogram? AM means next morning. Echocardiogram to assess LV function, or schedule pharmacologic stress testing, or send for emergent left heart cath, or CTA for suspected pulmonary embolism. Similar type EKG, presentation a little bit different. All right, most of them correct, but a lot of people still chose A and B. Okay, we just asked you what's the next appropriate action. Okay, all right, let's discuss that. Let's go from here. Okay, let's look at the slide here, and also let's go for discussion. This patient presents with acute coronary syndrome. Okay, and though the ECG look like dynamic T-wave inversion type, we call it like biphasic T-wave. That is one of the possible like Whelan's-like syndrome. Okay, Whelan's-like EKG, not the syndrome. Whelan's-like EKG. But there's a biphasic T-wave there, but the clinical presentation a little bit different. The patient still having chest pain while in the emergency room. When you see in the emergency room with biphasic T-wave changes and acute coronary syndrome and continuing chest pain, definitely you need to think about heart catheter, more like invasive intervention. Okay. The question right now, whether you need to take the patient directly to the cath lab right now, that we call immediate invasive approach, like shortly within 2 hours as soon as possible, or whether you need to do like early invasive therapy. That means you can take him the next day, because our interventional cardiologist at home doesn't want to come to the hospital in the middle of the night. So we just cool him down with some aspirin, heparin, statin, beta blocker, and then we'll do it in the morning. Or we could do ischemia guided strategy, okay, with a low TMS score and GRACE score low, that we can do the ischemia guided strategy. Or in some certain patients that we do, that we have to think about before going to heart cath, we call delayed invasive strategy, okay. If some patient has like kidney dysfunction, low EF, PCI, prior CABG, but their score is not on the high side, in the mid-level score, they will need intervention, but you have to think about what's the risk and benefits to do invasive strategy to these patients. So this is the risk stratification you need to keep in mind, okay? So you know that the previous patient needs heart catheterization first. Question right now, whether he needs to go in now, we call immediate invasive strategy. Yes, because the patient is having refractory angina. You probably already treated, giving probably aspirin, beta blocker, heparin, and nitro. Patient is already there, still having chest pain. And also, if the patient has any symptoms of heart failure or any new onset like a heart murmur, like particularly the mitral regurgitation, okay, and if there's any hemodynamic instability on the patient, if you see that blood pressure drop, or whether there's any concern about cardiogenic shock coming along or something like that, okay, and recurrent angina that the patient has been experiencing, then our patient, and definitely if there's any arrhythmia going on this patient, like if there's any you see VT or BP, definitely the patient needs to go immediately to the cath lab. So the patient. So these are the things you need to keep in mind, like immediate invasive strategy, early invasive strategy that is within 24 hours, and delayed invasive strategy within 25 to 72 hours, or ischemia guided strategy that low risk, you need to do a stress test, then do risk stratify. Because this is very important for our trainee physicians, this for the board, and also you need to know exactly when to call the interventional cardiologist to come in right now to do that, okay? Let's look at the coronary angiogram. Patient went to, we see very tight lesion in the LAD, proximal LAD, and definitely the patient got stented, okay? But the question hasn't stopped here. Let's go further, okay? So he underwent stenting in the LAD, as we saw above, and he definitely received all the treatment that we do, aspirin, ticagrelor, metoprolol, statin, and the echocardiogram shows mild hypokinesis in the anterolateral wall with EF of about 45 to 50%, okay? He remained stable overnight, no problem. But in the morning, when he was eating breakfast, he started having chest pain again, all right? So it says that it's radiated to the throat, lasting about 3 to 4 minutes, called the nurse did an ECG. This is the ECG, okay? And I'm going to show his prior ECG, just one. This is his prior ECG, first ECG, biphasic TUF changes, okay? And at the next day, just 1 second, next day after the stress test, after the heart catheterization and stenting, when he was having breakfast, and that time he's having chest pain, nurse did the ECG. Okay, so anybody can comment what's the difference there in the ECG? So we definitely see, anybody can comment? Our participants, please. Nothing unusual, but there's some change. You can just comment on that. We can go forward. All right, there's some. We see that there are some changes in the TUF abnormality. Initially, it was biphasic. Now we see fairly more deeper TUF inversion. Okay.
Dr. Hawk,
Yes.
Is there any difference of this issue with your case number 1? That is issue of the case number 1.
No, that's I'm just presenting similar ECGs in different presentation.
Right.
Similar looking, yes, and that's the focus of the talk today. Okay, you looked at the ECG. Okay, now what do you want to do with this ECG? Okay, so it's having chest pain again in the morning when he was eating breakfast. Nurse, he called the nurse did the ECG and they sent the ECG to you. And what are you going to do? Take him to the cath lab since there's a suspicion for a stent reocclusion. His new ECG changes suggest acute coronary syndrome. Start back on heparin drip because you're suspecting acute coronary syndrome, or just plan for discharge home with pantoprazole and arrange for outpatient follow-up, or get an emergent echo to assess new wall motion abnormality. Because this question will come to our fellow cardiology fellows there to make decision what to do on these patients. So you can answer those and you can discuss. All right, it's a very interesting distribution, okay? That's the thing we really like to discuss because I am asking our young physicians to listen to what we discuss. Is very important to recognize this pattern of ECG, okay? First of all, most of them answered A, 65%. And look at the clinical scenario on this patient, okay? The patient had chest pain for about 3 to 4 minutes. That's it. Okay. And it happened when he was eating breakfast. Okay. With radiating through the throat area. So before you take him to the cath lab, you really need to go to the patient and examine the patient, talk to the patient. Okay. He did fine overnight and he actually ambulated in the afternoon. He had cath stent done in the morning. Ambulated in the afternoon, he walked fine, no problem with that. So, and when you looked at that, the ECG, in the morning when he was having breakfast, having chest pain, and pain lasted only a few minutes, and it's gone. Okay, and you ask him, how the character of the pain, whether there's any burning sensation with the pain, whether any burping, belching with the pain, because with stent reocclusion, normally it's a severe pain. And you would expect significant change on the ECG if it's reocclusion, acute reocclusion on the of the stenting, because they have severe pain. That's not going to stop that within 3 to 4 minutes. So clinically, it's very unlikely the patient had reocclusion of the stent. Okay, very unlikely. So you don't want to take him to the cath lab. Okay. Another thing to understand, recognize the pattern of the ECG, because when you do. Yes, we suspect that the patient having acute coronary syndrome. There's a biphasic TOA abnormality we see, slight positive and slight negative. Now I see in the next morning, deep TOA inversion. That's the normal evolution of the EKG after reperfusion. Normal evolution. If you do ECG on patients, a lot of time we see without any chest pain, the similar looking ECG you do, you look at that, you'll find it in the next morning. So, but if you look at the Whelan-Strom, the first ECG when it presented was type A, and the next day is type B. But you need to understand that it is a normal phenomena after you open up the artery, after you reperfuse the artery, biphasic TOA can change to type B Whelan, that is, TOA inversion. So it is normal, and most likely the patient had acid reflux after he ate. It happened when he was eating, and after 3-4 minutes gone. If it is reocclusion, if it's acute coronary syndrome, reocclusion, the pain will not go away that so soon. So clinically, it's very unlikely that, and you'll have more changes on the ECG. Clinically, it's very unlikely that the patient had the stent reoccluded. So you don't have to take him to the cath lab. You just do, what I do, I just let him walk on the hallway, okay? Like we call poor man's stress test, okay? 5 times on the hallway, no chest pain, patient can go home because it's a normal evolution of the ECG, and put him on some pantoprazole for the acid reflux and set up for outpatient follow-up. So you see, it's a significant understanding of this pattern of ECG to recognize it is a normal variant of evolution of the ECG after angioplasty. So you don't need to take him to the cath lab. Just send him home with acid reflux medicine. But let him walk, no problem on the hallway. You don't have to do any other testing. You can follow the patient as an outpatient. But definitely he needs to be all cardiac medications that's supposed to be. All right, let's do its third case. If any question, please ask me. I would be happy, or our panelists can answer. We have a lot of interventional cardiologists here. Any question, or we'll go forward? Because the reason is who answered, our audience, please ask questions, because that's the way you learn, and we would be happy to explain as much knowledge we have. Okay. All right, let's go to the next case. 58-year-old, little bit obese, female with a history of hypertension, diabetes, cholesterol problem, came to the emergency room with complaint of recurrent chest pain. And that happens mainly in emotional stress or anxiety situation. She doesn't have any short of breath, okay, no dizziness, no passing out spell. When the patient came to the ED, he was pain-free. He was pain-free when he came to the ED, okay? Lisinopril 10 milligram, atorvastatin, metformin, vital signs stable. The ECG showed like that, okay? The reason I'm showing the ECG, they look alike, but they might present with different scenario. But remember the pattern of the ECG, okay? We call Whelan pattern, okay? But, here we see the biphasic T wave and slowly more inverted in more V4, V5, V6. But the patient definitely has been having recurrent angina, okay? In the situation, when you see biphasic T wave and angina, okay, let's go to the question and see what you think. Okay, let's answer the questions, please. So should we start the patient on aspirin, heparin D, beta blocker, hydrostatin, and treat conservatively since the patient is pain-free, okay? Or get an echo for assessment of LV function, or schedule for pharmacologic stress testing for assessment of ischemia, or schedule for CTA for pulmonary embolism, or center for heart catheterization. Question and answer. So you can show the answer sheet. Sorry, to answer them. Please answer the questions. Okay. Actually, there should be another one E here. Okay.
Yeah.
All right, that's okay. All right. So let me answer that. Yeah, any time you see this type of ECG, okay, and there's a presentation, a history of chest pain, recurrent chest pain, but the patient is pain-free, I think this patient deserves to go to the cath lab. Okay, that's one of the management strategy. I think most people will agree. Okay, and okay, all right. So a lot of people answered A. All right, the patient. Okay. All right, the patient went to the cath. No, this is echocardiograms. It reveals a little bit of hypokinesia in the anterior and septal area, and EF is about 55% and mild MR, okay? And I'm going to try to play that cath film. Just very carefully watch that, okay? All right, let me play around. So this is when the heart is relaxed, okay? And the coronary fills in the diastole, right? not in the systolic phase, in the diastolic. When the heart is relaxed, I see good feeling of the coronaries, okay? And then, and then when it is in systole, it's almost, we don't see much the medial AD area, okay? Feeling of the coronaries, okay? All right. So you can look at that. There's not much disease there, but what we have, we see that in diastole it's feeling well, okay? But in the systolic phase, when I'm putting the systolic phase, almost obliterating the LAD. That is called myocardial bridging. Myocardial bridging. They can present similar looking EKG that we mentioned also. Not necessarily exactly, they'll present same way, they might not present with any changes. But since the patient having chest pain, it came after the chest pain and came to the ER, patient is pain-free. So that's the, but same we call Whelan pattern ECG the patient presented, but she was found to have a myocardial bridging, okay? So what myocardial bridging is? Breathing is, normally we know that the coronaries runs above the muscle, right? The big arteries then go with the perforator, septal perforator or other perforator, they go inside more deeper and to the endothelium, deeper in that area. But the big coronaries are on the epicardial surface. But when these coronaries, they're born with that, they sometimes could be in different positioning, depending on that. It's called partially tunnel, there's half of them. If it's deep inside, it's a thin myocardial bridge, thick myocardial bridge, very thick, and really very, very thick, okay? Depending on how deep the course of the epicardial artery goes in the myocardium, that causes the myocardial bridging, okay? Because if it is partially tunnel, like halfway through, they might be asymptomatic, okay? But if they're just going a little bit deeper in the myocardium, they could be potentially symptomatic. And interestingly enough, this patient presented with a we call Whelan syndrome and turned out to have a myocardial bridging, okay? Because if you look at that how many people, what's the incidence and prevalence of myocardial bridging, okay? If you look at the autopsy report, and you would be surprised that almost 86% might have some sort of bridging, but most of them are asymptomatic because most of them, they're partially tunnel, okay? But it's they're deep in tunnel, as deep they go, they definitely become symptomatic, okay? So you need to be careful when you do the heart cath. You might see, okay, normal arteries, but you have to look at the systolic, diastolic phase carefully, understand, because the patient is symptomatic, patient is having symptoms. And particularly you need to be careful on those patients who are young patients, who are athletic patients, and they are jogging, running, and those type of patients they have different kind of, not only chest pain, they might have different kind of arrhythmia, non-sustained VT, even sudden cardiac death is possible. But when you do just by the heart catheterization we get around 0.5 to 16% only, okay? But nowadays, a lot of time we do coronary CT angiogram, and they are similar. They can find more of those myocardial bridging as comparable to autopsy report. But also another important thing, it really gets more worse when the patient has hypertrophic cardiomyopathy, because a lot of hypertrophic cardiomyopathy patients, they have chest pain, and they get worse because they already have too much myocardium per 100 gram of tissue. Like you have, like normally, as for example, you have like from 100 gram of tissue, one vessel going down there, but if you have 200 gram tissue, but the vessel is same, so you'll have artificial ischemia there because it's not enough to supply the whole 200 gram of myocardial tissue. So they have artificial ischemia there. On top of that, if they tunnel through the muscle, definitely they are symptomatic, and this type of patients are more prone to have sudden cardiac death in hypertrophic cardiomyopathy, okay?
So Dr. Hawk,
Yes.
how did you manage this case? This patient has got the acute coronary syndrome as presentation, but myocardial bridge on cath.
Yes, I'm coming to that, okay? So as the main another thing that please look at that the slide. As we talked about that, the coronary perfusion happens in diastole, but in systole it gets squeezed. Okay, but the problem is that they are more symptomatic. If the tunnel is too long and under the myocardium, then the coronary perfusion can be impaired even in diastole. It extends to the diastolic phase. And that is proven by intercoronary FFR testing or ultrasound testing. You can see that even in the diastolic phase, normally we see the normal opening, but it could be still squeezed because they don't recover in the diastolic space. And particularly it gets worse when the patient is tachycardic, because when you have tachycardia going on, high heart rate, they have decreased time of feeling in diastole. Decreased time of feeling, so they get more chest pain. Okay, and definitely another common phenomena we see, and interventional cardiologists definitely have noticed that when you have myocardial breathing, as for example, it's going inside the myocardium. This is a superficial artery is going inside, but at the very beginning, before the tunneling, at the very beginning, they have different shear stress. Okay, because the structure is different. They're going inside the myocardium. So in the beginning of the tunneling, because of different shear stress, the different pressure of blood flow in that area, hitting that area, they get more endothelial dysfunction. Okay, and they're more prone to have blockage, real blockage, like they're more prone to have atheroma. Okay, but that alone is not the cause for their chest pain or symptoms, because the tunneling, low blood flow, that is definitely causing it more problem. But the low blood flow inside the myocardium during systole, and sometimes it extends to the diastole because the tunneling through the myocardium, they are more ischemic. Okay, so and sometimes what happens that we call milking away, because as you see when you do the heart cath, we see that in systole it disappears and then comes back in diastole. We call milking away effect. That's just gone and comes back, gone and comes back, but they don't have real blockage. That's the tunneling. But some people have blockage at the beginning of the tunneling because of the shear stress change in that area. Okay. So, so how we treat these patients? Initially we saw that blockages at the beginning. Okay, we thought that maybe we'll open up that blockage and they might do better, because there's some study, several studies done and I think what happened, some people initially started stenting that area, but normally the data we are getting right now, they don't have good outcome on that. Okay, because on those data we see that they have more ischemic events. They have more like target vessel revascularization. They have to go it again to open it up again. And they had more problem with like stent fracture, because it's in the myocardium, very rigid, and it's when a stent is a very rigid structure. When the heart squeezes, they can fracture the stent. Okay, and reocclusion. That's common. So that practice has gone away. So now there's no recommendation right now to put the stent in myocardial bridging, despite that the initial part could be some true atheroma building up there. So and the data we have, as we see here, target vessel revascularization 42 in the stent group, they had more problem. Okay, they are more MI, more death. Okay, so it's not recommended nowadays putting stent. Okay, so and as we see that stenting called questionable efficacy on the angina relief, but they are not lasting. They have perforation about 6.3% in stent restenosis, late stent thrombosis, and high risk of stent fracture. So it just came out of favor, that technique. But the main treatment right now, just let's go backwards. Definitely risk factor modification, relieve potential triggers if it's possible, antiplatelet therapy if atherosclerosis is present, but main treatment really beta blocker. Okay. Or if they cannot tolerate beta blocker, then calcium channel blocker. So what beta blocker does, First of all, they decrease the heart rate, they decrease oxygen consumption, okay, and they decrease the contractility of the heart rate, okay. That gives you more time to fill in diastole. That's the main effect, because those two patients, they do better if they're, some symptomatic, they're walking, jogging, having chest pain, and you should give a trial of beta blocker, and a lot of time we see they do better with the beta blocker therapy. If the blood pressure is on the low side, you can try avobrad in those patients. But one important thing, this type of patient should not get vasodilator. Nitroglycerin is contraindicated in these patients. That's very important. Do not give long-acting nitrate in this patient for chest pain. What's going to happen, like the patient has tunneling, like there's tunneling inside, okay? And if you give nitroglycerin just above that tunnel, the vessels gets bigger, there's redistribution of blood flow from that tunnel away from the blood flow. So they get Steele syndrome because they already compromised inside the myocardial course. They have a Steele syndrome, so it makes it worse. Sometimes it can cause angina more. Okay, you give nitro, patient having more angina. You need to think about the patient has a myocardial bridging going on. So medical treatment is the first approach, okay? And definitely, if the patient very symptomatic and your medical treatment fails, then the treatment is surgical, okay? The main, if the patient is partially underneath, not very deep and not very long, then we call unroofing, basically you put incision on the muscle and take the artery out. Okay, we call unroofing of the coronary artery. It is the ideal treatment, okay? But if the patient is like more than 25 millimeter long bridge inside the myocardium and half a centimeter deep, then the roofing would be difficult to cut so much myocardium. Then you have to just bypass surgery, okay? Sometimes it is most commonly happens, in the LED territory, you can do robotic surgery with Lima to LED. You can, without opening the chest, you can do that, or mid-cap surgery, you can do that with minimally invasive surgery. But you need to be careful also, because you need to really understand the depth and length of that. And you have to really initially define either intercoronary, you can do FFR testing or some sort of functional testing inside to make sure they are truly symptomatic with that. Because if they are not that functionally active, obstruction of blood flow, if you do bypass, then what's going to happen? The blood will still flow through the myocardial bridge tunneling, and the graft will be atretic, it will close off. So you need to have functional testing before making the decision whether the patient needs to go for bypass on that. But interestingly enough, this patient presented the similar looking EKG that we saw in the Whelan syndrome. Okay. All right, let's do another case. 70-year-old female presented to emergency room with chest pain, about 30 minutes duration. It began 20 minutes after she received the news that her husband in critical condition in the intensive care unit and may need some surgery. Basically, it's huge stress for her, okay? And age about 70. Pain was described 5/10 non-radiating, substernal, and associated lightheadedness. Vital signs stable, nothing much, despite that she's nervous and breathing a little bit faster, but otherwise okay, but no hypoxia, okay? And there's some slight murmur, apical systolic murmur at the apex. And this is the ECG, okay? Look at that, similar looking ECG, but the presentation is different, everybody. Okay, here I'm just going to go ahead and read that. Definitely sinus rhythm, but the main concern that we have, V2, V3, V4, V5, symmetric, all along, like really deep TO inversion all along, okay? It's a little bit, looking like type B Whelan, but a little bit more pronounced. But you have to look at the clinical scenario also, okay? So now let's look at that. Let's read the questions and see whether you can answer that. What do we need to do in this case? Okay, let's start her on aspirin, heparin drip, beta blocker, high dose statin, and treat conservatively. Okay, get an echocardiogram to assess LV function. Schedule for pharmacologic stress testing for assessment of ischemia. Next morning, if enzymes doesn't rise that much, okay, and you can do a CTA for pulmonary embolism or Center for Heart Catheterization. All right, please answer this question, because look at the clinical scenario presenting ECG. That's also very important. You can put the questions for answer sheet there for them.
Poll, please.
All right, we'll see the questions. Sorry, answer. Let's see.
Where is the poll, Rivu, Kamrul?
All right, let's see if not. I'll push. Okay, maybe there's some difficulty putting that. Okay, let's see. This case you can argue, what to do. Okay, look at the scenario of the patients. Okay.
Can you call any participant?
Yes. All right. Yes. Any participant would comment on this case and what to do.
Bishal Sreshto from Nepal. Dr. Bishal Sreshto. Can you hear us? Dr. Bishal Sreshto from Nepal. Bishal Sreshto. Or Kani is Ananya from Nepal. Anyone can answer. Bishal Sreshto.
Or anyone from whoever willing to, please. Now, this is a case scenario that you're going to see in your practice. So go ahead and discuss that.
Anyone volunteers?
All right, I think we'll start discussion.
Yeah, technical problem, I think.
Yes. Should we go forward after it? All right, I'll go forward. Okay. So let's see, the presentation of this case, let's look at that elderly lady, okay, and start having chest pain, significant chest pain after hearing bad news, like it's a significant stress to her. That husband in the emergency room, in the ICU and needs some emergency surgery or something like that, and having chest pain. She did fine before, no problem with that, okay, at her age. And the ECG pattern is that we call a more pronounced Wellen-B type syndrome, like deep TO inversion, okay? That type of deep TO inversion, you see that a few cases you can look at it, right? One common thing that, whether there's anything going on with stress, cardiomyopathy or something like that. Another thing also concern about the patient having stroke, okay? Neurologic like TO inversion that we call it, but the patient doesn't have those type of symptoms in the physical exam. So or the patient is having true acute coronary syndrome, okay? So, but this case, you can argue whether you need to take her to the cath lab right now, or you can do in between certain things to, confirm your thought process, because as in medicine, we always try to analyze ourselves, and also each clinical scenario is different. It's not like algorithm that you have to do everything that you need to do with the TO inversion, okay? But in this case, you have high suspicions that, elderly patients, whether the patient has something going on with the stress. I think the answer B would be the right option. They get a quick echocardiogram, bedside echo, and you can, if you see certain pattern, then your diagnosis could be very obvious down there. And let's look at that, what the patient had, okay? So I'm going to try to play that, okay? Look at that, okay? We see that mid to base is contracting very well, okay, in this view. And you see that apical hyperkinesis down there, okay? And the similar, okay? You see that mid to base is very contracting well, but the whole apex and from mid to apex, and it's a multi-regional, it's not one single vessel distribution, okay? So inferior wall, mid to apex, anterior wall, mid to apex, apex, all are down, okay? Here you can see better, okay? This pattern you need to keep in mind when you see the echocardiogram. This is pure Takotsubo pattern, okay? Pure Takotsubo pattern. And that kind of fits the story with the patient, elderly patient, and happened with stress, okay? Serious stress, okay? And presentation of Takotsubo can happen for many reasons, okay? I had a patient who had hip surgery, like for the last 4 or 5 years, I had at least 6 or 7 cases of Takotsubo. After hip surgery, patient actually had cardiac arrest, okay? And apparently had arrhythmia and had cardiac arrest in VT. And it looks like that we did an echocardiogram and exactly the similar pattern, okay? So it could be stress, it could be just any kind of pain, severe pain can do that. Different kind of triggering factors should be associated with that, okay? And there's a question about with the apex, whether there's any clot or anything. We did a contrast study on that, and looks like all right. And you can see very good looking of the mid to base segments vigorously contracting, okay? That's a classic for Takotsubo, okay? And we don't see any clot in the apical area, because sometimes they can form clot because the akinetic apical area that, for the time being. And it's extremely important to recognize these patients and treat those patients as quickly as possible with, definitely their LV function is down. The beta block is the treatment choice, and also ACE inhibitor or ARB, you need to initiate that. But good thing is that they recover very quickly, okay? And by, Mayo criteria, that this type of patient, and if you do the heart catheterization, you can see that mid to base contracting very well and apical ballooning in systole, okay? All right. This type of patients will require heart catheterization, okay? But in this particular patient that we had, we decided not to do that. The reason being, the patient had stage 4 lymphoma, has been on chemo, and her troponin was minimally elevated, okay? So we decided, we wanted to do heart cath, but after looking at all her factors and all these things, we decided not to do it. And we treated her conservatively, but by guidelines, by criteria, you should do that to confirm that no LAD disease, okay? But in this particular scenario, we didn't do it because of you have to manage, balance each patient, the clinical situation, longevity of life, quality of life. And actually we repeated the echo in about 2 months later, our LV function normalized totally, 55 to 60%, and this wall motion abnormality is gone. Okay. So I presented these cases. I want to make sure that our audience and the trainees that you're here to look at that, recognize this pattern, because this biphasic TUFs, always you have to be on high alert. Okay. But they can present in different scenario though. Okay. Because it could be normal evolution of reperfusion pattern of the ECG, that any patient get a heart attack, open up, and you can see the TUF inversion like type 2 Wellen, we call Wellenoid EKG, that's normal variant. Another one, really, they can present in the either type 1, type 2. You need to be alerted with that because they had very tight lesions sitting there. They are very close to get heart attack and acute ST elevation MI and cause problem. And let's see, I have some ECG because I had very interesting one patient. Okay, like look at the ECG. This patient basically is another pattern like we call inferior Wellens. Okay, presented with some TUF inversion in the inferior leads. Okay, and then next ECG is kind of normalized. Okay, patient still in the ED. Okay, and then about 10-15 minutes later, he having chest pain again, and we see slight elevation of ST. Even continued to have chest pain. 5 minutes later, look at the ECG. Huge ST elevation in inferior leads. So Wellen type ECG, you cannot ignore that. That's the bottom line of discussion today. Make sure keep in mind any dynamic TUF changes, they are waiting something to happen. Okay. So if you wait there and go home, and in the middle of the night, you put him on morphine, the patient might not feel pain, the patient having acute heart attack, and he is going to lose muscle and potential death. Okay. I'll conclude that way, otherwise. I think it's already more than an hour. Okay. Anybody want to discuss or any comments and or any questions would be happy to answer from the audience.
Thank you very much for your excellent presentation, Dr. Hogg. There is a question from Dr. Bishal Sreshto from Nepal. Actually, he asked the question during your second presentation. He wanted to know that your case 1, case 2, and case 3 are almost similar ECG. He wanted to know if the patient does not have any symptom, but presented with this kind of the ECG, what should be the management strategy?
Yes, the Wellen syndrome or dynamic TUF inversion, it has to come with two things. History is most important. Okay, if the patient had never had any chest pain, either resting or either resting or exercise or something, then it's a different scenario. Okay, but the Wellen syndrome, when we need to be alerted that patient had symptoms at home, he might not be having symptoms now, like pretty recent symptoms. Patient will tell you the patient having chest pain on exhaustion, chest pain on stress, anxiety. You cannot ignore that. You have to take it very seriously and go more invasive approach to rule out. If the patient never had symptoms, and look at previous ECG, whether the patient had a year ago or something, if the similar looking ECG, you don't have to do much. Okay, but normally they have some symptoms. It's not like normal looking ECG biphasic TUF. It's not normal. Okay, but that's the way. It's the recognition of the pattern. Okay, yes.